Okay, so the second recording, we're going to start with the female reproductive system. Depending on how the timing goes, I might break this one up into two, but we'll see. So in addition to the similarities between the female and male systems, the female system must also be capable of supporting a developing embryo and providing the nourishment for a growing infant. The internal female genitalia will include the ovaries, the uterine tubes, which are also referred to as the fallopian tubes, the uterus, and the vaginal tract. The peritoneum extends downward on either side of the uterus, which creates two regions or pouches between the uterus and the urinary bladder and the rectum. The vesico-uterine pouch and the recto-uterine pouch, respectively. And here we can see those internal structures. So the ovaries, these are the paired female gonads that are located on the lateral walls of the pelvic cavity. They produce the ova. They also secrete hormones, your estrogens, as well as progesterone, inhibin, and relaxin. The ovary will contain two distinct regions: an ovarian cortex, which is a superficial outer region where the process of oogenesis, the production of the gamete, occurs within sac-like follicles. They will also develop and mature along with the gametes. And then the ovarian medulla, this is an inner region where blood vessels, lymphatic vessels, and nerves are found. Each whole ovary will be held in place by three ligaments that provide structural support. The broad ligament, which is a large flat ligament that attaches to the ovaries, uterine tubes, and uterus, connecting these structures to the bony pelvis. The ovarian ligament, which connects the medial surface of the ovary to the uterus near the attachment of the uterine tube. And the suspensory ligament, which connects the lateral surface of the ovary to the pelvic wall and provides support for the ovarian artery and vein as well. The fallopian tubes, or oviducts, or uterine tubes, form the initial segments of the reproductive system. They extend medially from the ovary to superior and lateral regions of the uterus. They are covered by the peritoneum, and they are supported by a portion of the broad ligaments. The isthmus, this is at the proximal end of the tube. It is a constricted region that connects the tube to the uterus. And the uterine tubes will have several regions. You have the ampulla, which is an expansion at the distal end that connects the tube to the infundibulum. And then you have the infundibulum, which is a funnel-shaped opening at the distal end of the uterine tube. And then fimbriae, which are finger-like ciliated projections that extend from the edges of the infundibulum. And this is actually kind of a poor picture, but here you can see the ovaries. Here's the ovarian ligaments. And then this would be the uterine tubes here. This image is a poor picture because it actually shows like the ovary is directly attached to the uterine tube, and it's not. There's a separation there. So ovulation is when the immature gamete, called an oocyte, is expelled from the ovary. The fimbriae, which are the finger-like projections, will sweep the ovary surface to catch the oocyte and direct it into the uterine tube. The uterine tube smooth muscle will have peristaltic contractions, ciliated cells, and non-ciliated cells, which work together to move the oocyte towards the uterus. Fertilization will begin when the sperm cell binds to and penetrates the oocyte plasma membrane, and this typically occurs in the ampulla. The uterus, or womb, is the pathway for sperm to enter into the uterine tubes. It provides the site for the newly fertilized ovum to implant itself and where it can be protected and nourished as it develops. It is a pear-shaped hollow organ located in the pelvis, anterior to the rectum and posterior to the urinary bladder. It is composed of three regions: body, which is the main region; the fundus, the rounded region superior to the entrance of the uterine tubes; and the cervix, which is a narrow neck. The uterine wall is composed of three layers: the perimetrium, which is the outermost layer, extensions of the parietal peritoneum; myometrium, which is a middle layer that is composed of bundles of smooth muscle, which contract rhythmically during orgasm and childbirth; and the endometrium, which is the innermost layer that lines the uterine cavity and is composed of simple columnar epithelium. It forms mucous membrane that rests on the thin layer of the connective tissue, which is a lamina propria. The uterus will be held in place and supported by various ligaments. The lateral cervical ligaments will extend from the cervix to the superior vaginal to the lateral walls of the pelvis. The uteral sacral ligaments will connect the uterus to the sacrum posteriorly. The round ligaments will connect the uterus to the anterior body, and the broad ligaments, which will support the uterus laterally. The vaginal tract is the organ of copulation. It receives the penis and semen during sexual intercourse. It is the passageway for giving birth and also for menstrual flow. It is a thick-walled tube that extends from the cervix to the exterior of the body. It is parallel to the urethra, and it lies between the urinary bladder and the rectum. The vaginal fornix is a recess where the superior end of the vaginal canal surrounds the external os of the cervix. The vaginal wall is lined with transverse ridges called rugae, which stimulate the penis during sexual intercourse. The vaginal mucosa is composed of stratified squamous epithelium, which is able to withstand frictional forces. Mucus from the cervix will provide lubrication. Epithelial cells will secrete glycogen into the vaginal lumen. This is metabolized by resident bacteria and generates lactic acid, which helps to maintain the acidic pH of this region. A hymen is a vascular partition of mucosa near the distal vaginal orifice or opening. It's commonly ruptured during the first sexual intercourse. The female external genitalia will include the vulva, which is the external reproductive structures. You have the mons pubis, which is a fatty, rounded region overlying the pubic symphysis, covered with hair after puberty. The labia majora is a pair of elongated, fatty, protective skin folds that lie posterior to the mons pubis. The labia minora, this is a pair of thinner skin folds enclosed within the labia majora. The vestibule is a recess enclosed within the labia minor and contains the urethral orifice and the vaginal orifice. The paraurethral glands in the vestibule will discharge mucus into the urethra. The greater vestibular glands will secrete mucus into the vestibule during intercourse. The clitoris is anterior to the vestibule, is a small protrusion composed of erectile tissue. When stimulated, the erectile tissue becomes engorged with blood, and the tissue is innervated with sensory, motor, and autonomic fibers, as well as tactile pressure and temperature receptors, all of which are important for sexual stimulation. The female perineum is a diamond-shaped region located between the pubic arch anteriorly, the coccyx posteriorly, and the ischial tuberosities laterally. An episiotomy is an incision that's made in the tissues of the perineum to prevent natural tearing during childbirth. Tearing is much more difficult to heal than a surgical incision. And here's the external genitalia. The mammary glands, these are modified sweat glands. They are components in the integumentary system whose primary biological role is to produce milk for the newborn infants. Each mammary gland is within the hypodermis and enclosed with rounded skin-covered breasts. The breast is superficial to the pectoralis major muscle of the chest wall. The areolar, this is a hyperpigmented region just below the center of each breast, and it surrounds the nipple through which milk exits. Each mammary gland is composed of 15 to 20 lobules that radiates around and open into the nipple. Each lobe is supported by a fibrous connective tissue, fat, suspensory ligaments, and lobes are divided into lobules and contain glandular alveoli, which produce milk when women are lactating. The suspensory ligaments will attach the breast to the underlying muscle fascia and the overlying dermis. Contraction of the myoepithelial cells that surround the alveoli help to propel milk towards the nipple. Milk will pass from the alveoli into a series of mammary ducts, flow into the lactiferous ducts that open into the nipple. Deep to the areolar, each lactiferous duct has a dilated region, referred to as the lactiferous sinus, where milk can accumulate during nursing. Glandular structure of breast is mostly undeveloped in women who are not pregnant. And here you can see the lobules the lobules here, okay? And then you have the lactiferous ducts, which all will empty out into the areolar region here. So this is a table that just summarizes the structures and the functions of the female reproductive structures. Disease of the structures, breast cancer is the second most common type of cancer in women after non-melanoma skin cancer in the US. Over 200,000 cases per year, few hundred of which occur in men. Risk factors include maternal relatives with breast cancer, longer reproductive span, early first menstrual cycle coupled with menstruation continuing until later age, obesity, no pregnancies or first pregnancy after the age of 35, and containing the two breast cancer genes, BRCA1 and BRCA2. Unfortunately, most breast cancers are painless until they become advanced and have metastasized. The best way to prevent cancer from spreading is to detect it early. Monthly self-examinations can locate lumps that may be malignant. Mammograms, which are x-rays of the breast, can detect small areas of increased tissue density. It can detect many small malignancies that are not yet palpable in a self-examination. It is recommended in women over the age of 50 to have a mammogram every 2 years, and women with a family history of breast cancer to have regular mammograms before the age of 40. Treatment may involve chemotherapy, radiation therapy, lumpectomy, or a mastectomy. Okay, so now we'll look at the physiology of the female reproductive system. Oogenesis is the process in which the female gamete or the ova are produced. This differs from spermatogenesis in the following ways. It begins before the female infant is born. It is then suspended until puberty. Once reactivated at puberty, it continues until it ceases operation at menopause, somewhere between the age of 45 and 55 years of age. It occurs about once per month as part of the ovarian cycle. So before birth, the female stem cells, the oogonia, complete their mitotic division. They begin meiosis 1 between the 3rd and 7th month of fetal development, and these will form primary oocytes. The primary oocytes progress as far as prophase 1 before development is arrested. The primary oocytes will remain in prophase 1 throughout childhood and do not develop any further until meiosis resumes at puberty, when specific hormone levels trigger the initiation of the ovarian cycle. From puberty to menopause, approximately once monthly, 20 to 30 primary oocytes are stimulated to continued development. One or more primary oocytes completes the first meiotic division to produce 2 haploid cells. They actually differ in size. The smaller cell contains DNA but little cytoplasm, and it's referred to as a polar body. This is a non-functional cell, and it will disintegrate. The larger cell, which is a secondary oocyte, contains the DNA, most of the cytoplasm, and this has the potential to become the ovum. The secondary oocyte then proceeds to metaphase 2, and its development is again arrested. If fertilized, the secondary oocyte will complete the second meiotic division and divide it to form a second polar body and the ovum. Keep in mind that the meiosis of the ovum will not continue and will not complete unless fertilization has occurred. The first polar body occasionally proceeds through the second meiotic division, forms 2 polar bodies, both of which will degenerate as well. So oogenesis begins with an oogonium that has 46 chromosomes and produces 1 secondary oocyte that has 23 chromosomes. When fertilized, the second oocyte becomes the ovum with 46 chromosomes. Now, both spermatogenesis and oogenesis produce gametes and provide the same amount of genetic material. However, their gametes play very different roles in reproduction. Sperm are produced in high numbers for 2 reasons. They must travel through inhospitable female reproductive tract, most of which will not survive. More sperm entering the reproductive tract means more sperm will probably make it to the secondary oocyte. They also produce sperm, an enzyme that allows them to penetrate the secondary oocyte. But one sperm by itself cannot produce enough enzyme. Hundreds of sperm are needed for that to occur. In contrast, there is no reason for the female reproductive system to produce multiple ova at one time. It has a difficult time supporting more than 2 to 3 embryos during one pregnancy. When the ovum forms, it receives most nutrient-rich cytoplasm, whereas the polar body receives very little of it. This helps to support the developing embryo until it embeds in the uterus and begins obtaining nutrients from the mother. The situation differs for sperm cells. Only needs to deliver genetic material to developing oocytes, so excess cytoplasm is removed during spermiogenesis to keep the sperm small. Spermatogenesis produces millions of sperm every day in case they are needed. Oogenesis produces 1 viable secondary oocyte approximately once a month. And here's the different events that occur with spermatogenesis and oogenesis, comparing and contrasting the 2. So estrogen and progesterone are involved in a multi-tiered negative feedback loop that include the hypothalamus, anterior pituitary, and the ovaries. This is that HPG complex. This will be involved in the regulation of the female reproductive system, and this is very complex as it requires rhythmic fluctuations in hormones. The oocyte develops inside the ovarian follicle, which is a small blister-like structure within the ovarian cortex. Before birth, the primordial follicles are first follicles formed in the fetus that contain one primary oocyte. During childhood, most primordial follicles will have died through a process called apoptosis or programmed cell death. Some remaining primordial follicles will grow into primary follicles as oocytes, enlarge and develop into secondary follicles containing the arrested primary oocytes. One secondary follicle grows into a mature follicle or a vesicular follicle or a tertiary follicle about once per month. This contains a secondary oocyte arrested in metaphase 2. The vesicular follicle ruptures, resulting in ovulation of a secondary oocyte. The ruptured follicle then becomes the hormone-secreting structure called the corpus luteum, and this persists if the oocyte is fertilized, or it will degrade into scar tissue if fertilization does not occur. Now, the phases of the ovarian cycle will include a monthly series of events associated with the maturation of the oocyte and the follicle in the ovary. The maturation of one oocyte and its follicle takes many cycles, requiring up to 350 days to progress from the primordial follicle to ovulation. The first stage, which is the follicular phase, the follicle grows and develops in the following maturation events: the primordial follicle, a single layer of squamous follicular cells that surrounds the primary oocyte. During childhood, many primordial follicles begin their development into primary follicles. The primary follicle, this is a squamous follicular cells, become cuboidal and are called granulosal cells. Microvilli and thickle cells appear in the primary follicle. This forms a region called the zona pellucida that becomes important once fertilization occurs. The secondary follicle, the wall of the follicle thickens and deeper granulosa cells secrete follicular fluid. This forms pockets, small pockets, and increases volume and size of the follicle. Granulosa cells grow and stimulate cells in the ovary to form a layer of thickle cells around the follicle. In turn, granulosa cells produce estrogen from thickle cells secretions. The tertiary follicle, this is a small pockets of follicular fluid merge into a single large cavity referred to as the antrum. The primary oocyte and its capsule of granulosal cells project into the antrum on the stalk. Follicle continues to enlarge, creates a bulge in the ovary surface. The primary oocyte suspended in prophase 1 completes meiosis 1 to form the secondary oocyte and the first polar body. The secondary oocyte arrests development in metaphase 2. This will only complete second division if fertilization occurs. So this takes you through the follicular phase and the 4 stages, and it gives you a description of what's happening with the follicle at each stage there. So this is actually a nice figure. Ovulation phase, which is stage 5, this is the event at the end of the follicular phase. The vesicle follicle erupts from the ovary wall into the peritoneal cavity, ejecting its secondary oocyte and its granulosa cell layer, called the corona radiata. The vesicular follicle then collapses, and ruptured blood vessels bleed into the antrum. And here's that 5th stage. The birth of fraternal twins, non-identical, is a phenomenon that occurs when more than one vesicular follicle releases a secondary oocyte. The birth of identical twins results from the fertilization of a single oocyte by a single sperm, followed by the separation of dividing cells during development. During the luteal phase, this is stages 6 and 7, the ruptured follicle becomes an endocrine organ called the corpus luteum. The yellowish corpus luteum is formed by the remaining granulosal cells and thecal cells. These will secrete progesterone and, in some cases, estrogen, and will persist for about 3 months and then degrade if pregnancy does not occur. The corpus albicans is a whitish knot of scar tissue that marks the end of the ovarian cycle. Remnants of previously active corpus luteum after it ceases secreting hormones and is degraded by macrophages. Here, stages 6 and 7. And here are the full 7 stages of the ovarian cycle. So the ovarian cycle averages about 28 days overall, with each stage accounting for the following amount of time. The follicular phase, which is stages 1 through 5, extends from day 1 to day 14. The luteal phase, which is stages 6 and 7, extends from 14 to 28. The follicular phase may vary. The luteal phase is pretty constant. Now, the regulation of the ovarian cycle requires rhythmic fluctuations of hormones from the hypothalamus, the anterior pituitary, and the ovaries. They interact via the negative feedback loop, which is introduced in the male section, the HPG axis. Of note, ovulation is triggered by a positive feedback mechanism, something that's rarely seen in the human body. So your first tier control is the hypothalamus secretes gonadotropin-releasing hormone. The second tier control is the anterior pituitary releases luteinizing hormone and follicle-stimulating hormone in response to the gonadotropin-releasing hormone. Luteinizing hormone then stimulates the thecal cells to secrete the androgens, as well as target the granulosal cells. The follicle-stimulating hormone stimulates the granulosal cells in the follicles to secrete estrogens, convert androgens to estrogens, and secretes inhibin. The effects, the estrogens typically will stimulate solitary dominant follicle to continue developing into a vesicular follicle. The new vesicular follicle eventually produces enough estrogen to exert a positive feedback on the anterior pituitary to trigger a large increase in luteinizing hormone called the LH surge. It's this LH surge that's accompanied by an increase in FSH level that will trigger ovulation, as well as the corpus luteum to produce additional progesterone, estrogen, and inhibin. The increased levels of estrogen and inhibin will exhibit a negative feedback control on the HPG axis. Estrogen will inhibit gonadotropin-releasing hormone and LH secretion, while inhibin inhibits FSH secretion. This also prevents other primary follicles from beginning development too early. In the event that fertilization should occur, progesterone from the corpus luteum inhibits the release of gonadotropins continuously for the duration of the ensuing pregnancy. In the absence of fertilization, the corpus luteum will degenerate into the corpus albicans. Estrogen, progesterone, and inhibin levels will decrease. Gonadotropin levels will then begin to rise, and that will initiate the whole cycle starting over again. Estrogen and progesterone will also stimulate the development of the female sex characteristics. This will include the maturation of the sex organs and the development of the external genitalia, as well as the maintenance of anatomical features that are unique to females, such as breast development and fat accumulation around the hips and thighs. Progesterone is responsible for the maintenance of pregnancy once fertilization has occurred. Estrogens have effects on many other tissues, including increasing bone density and increasing the beneficial HDL cholesterol levels. Estrogen will also promote blood coagulation that can lead to the formation of blood clots under certain circumstances. And here's that HPG axis. The uterine cycle, or the menstrual cycle, this is a series of cyclical events that the uterine endometrium goes through each month in response to the fluctuating levels of the ovarian hormones. The uterine changes are coordinated with estrogen and progesterone levels released during the ovarian cycle. Under control, the gonadotropins released from the anterior pituitary. When you look at the endometrium of the uterine wall, there are two layers, a stratum functionalis, or functional layer, and a stratum basale, or basal layer. The functional layer is the location of the cyclical changes in response to the fluctuating hormone levels. It will actually detach from the uterine walls and is shed with discharge of about 35 to 50 mils of blood and other materials from the vaginal tract, usually monthly during menstruation. The thinner, deeper layer of the stratum basale does not thicken in response to hormone fluctuations, nor is it shed during menstruation, but it actually replaces the stratum functionalis at the end of menstruation. Many endometrial or uterine glands change in length as the endometrial thickens. Main uterine vascular artery supply are the uterine arteries, which are branches off of the internal iliacs, which those are branches off of the abdominal aorta. The uterine arteries will terminate into a stratum functionalis as a spiral or coiled arteries. And those spiral coiled arteries are important because they will actually corkscrew up, which will cut off blood supply to that layer, and that's why it eventually sloughs off if fertilization does not occur. The uterine cycle proceeds through 3 phases during an average 28 days. The menstrual phase, this is days 1 through 5, where the uterus sheds the stratum functionalis, resulting in menstruation. You then have the proliferative or preovulatory phase. This is when the new stratum functionalis is generated with the endometrial glands, the spiral arteries and veins, and begins to thicken or proliferate. These glands enlarge and the veins and arteries increase in number, and the ovulation occurs around day 14. During the secretory phase, these are days 15 through 28, the spiral arteries convert the stratum functionalis into the secretory mucosa, and the endometrial glands will secrete nutritious glycogen-rich fluid, or uterine milk, into the uterine cavity to sustain the embryo. If pregnancy does not occur, the cells of the stratum functionalis die, and on day 28, the menstrual cycle begins. If pregnancy does occur, the secretory phase continues and the uterus continues to develop in preparation of the embryo. And here you can see the thickness and the blood supply of the uterine walls during this 28-day period. Now, the hormonal control of the uterine cycle, you're going to have the regulation of the uterine function requires rhythmic fluctuations of hormones from that HPG axis. When the menstrual phase of the uterine cycle begins, FSH and LH start rising, while the ovarian hormones are still low. By day 5, the ovarian follicles increased estrogen production. During the proliferative phase of the cycle, estrogen levels rise and stimulate LH and FSH surges. This triggers ovulation. Ovulation produces the corpus luteum, which then will control the release of progesterone. During the secretory phase of the cycle, rising progesterone levels and decreasing estrogen levels will inhibit LH. If fertilization does not occur, progesterone levels decrease, the stratum functionalis breaks down, and menstruation phase has begun. If fertilization does occur, the outer layer of the embryo developing begins to secrete human chorionic gonadotropin, or HCG. This keeps the corpus luteum from degenerating and progesterone levels remain elevated. And here you can see the hormones of LH and FSH from the anterior pituitary and estrogen and progesterone over that 28-day period. This is a table, the big picture of the hormonal regulation, looking at the uterine cycle, your hormones, as well as the ovarian cycle, all laid on top of each other there. And this is just looking at the ovarian cycle and the ovarian hormone individually. This table summarizes all of the hormones that are secreted for both the male and female reproductive systems, the source of those hormones, their target tissues, and what that hormone is responsible for affecting. So let's talk about the female sexual response. During sexual excitement, the vaginal mucosa, vestibule, and breasts become engorged with blood. The clitoris and nipples become erect, and increased activity of vaginal mucosa and vestibular glands will lubricate the vestibule. Tactile and psychological stimuli mediated by the autonomic pathways will promote sexual excitements. An orgasm refers to a period with which women experience intense feelings of pleasure without ejaculation. The uterus experiences peristaltic waves of contraction, and the cervix pushes into the vaginal tract. These activities may draw semen further into the reproductive tract. Unlike males, there is no refractory period, and conception is not actually dependent upon an orgasm actually occurring, unlike with the males. So in other words, a female can have multiple orgasms, and an orgasm is not required for fertilization. The female libido, or sex drive, may be related to the androgen dihydroepiandrosterone, or DHEA, which is produced by the adrenal cortex. The androgens and estrogen appear to influence the sexual behavior because interactions with the hypothalamus. Many women will experience fluctuations in libido in response to monthly fluctuations of estrogen and progesterone. Puberty for most girls will begin a little bit earlier than the males, and that will be somewhere between the ages of 9 and 11, when secretions of estrogen and progesterone increase from the ovaries. Prior to puberty, low gonadotropin releasing hormone levels keep LH and FSH levels low. This keeps estrogen and progesterone levels low as well. At puberty, the hypothalamus becomes less sensitive to low levels of estrogen and progesterone, and gonadotropin releasing hormone levels will increase. The elevated gonadotropin releasing hormone levels will stimulate the HPG axis, and blood levels of estrogen and progesterone will increase. This results in the development of female secondary sexual characteristics. The first sign of puberty in girls is budding breast, followed by the secondary sex characteristics. The appearance of pubic and axillary hair, and an increase in secretions from the sebaceous glands. Adipose tissue increases in the subcutaneous layer. Adipose tissue increases in the subcutaneous layer throughout the body, with the additional deposits in the hips, thighs, and breast. Individual height increases and the hips widen. Menarche is the first episode of menstrual bleeding. This occurs approximately 2 years after the onset of puberty. This will not occur unless a girl has at least 15 to 17% body fat. Leptin, which is a hormone secreted by adipocytes, stimulates gonadotropin secretion. If leptin levels drop due to low body fat percentage, gonadotropin levels will decline. Directly affects the HPG axis. After puberty, the reproductive cycles continue at regular intervals until 4th or 5th decade, when they become irregular. The female climacteric is a period from the onset of irregular menstrual cycles until their complete cessation. This varies, but can last as long as 5 years in some women. Menopause is the point when menstruation has not occurred for at least 1 year. The number of primary follicles left that can respond to luteinizing hormone and follicle-stimulating hormone is diminished after 30 or more years of ovarian cycles. Atresia, this is a process in which immature follicles degenerate and are reabsorbed during the follicular phase of the menstrual cycle. The remaining follicles are less responsive to the gonadotropins, so less estrogen and progesterone are secreted. Ovulation does not occur and estrogen and blood levels drop significantly, while LH and FSH continue to be secreted as pituitary is no longer inhibited. The reduced levels of estrogen and progesterone may alter female secondary sex characteristics. The breast, uterus, and uterine tubes may shrink, while pubic and axillary hair may thin. Bone density may decrease, increased risk of developing osteoporosis. The vasomotor signs that include hot flashes may occur due to changes in rhythmic secretion of the gonadotropin-releasing hormone by the hypothalamus in response to decreasing blood levels of sex hormones. Women may experience many other non-specific symptoms, including migraine headaches, backaches, fatigue, and mood swings. Early menopauses are the occurrence of menopause before the age of 45, while premature menopause occurs before the age of 40. Female infertility, this is the most common reason for female infertility, is a problem with ovulation. Without ovulation, there is no secondary oocytes to fertilize. This could be due to polycystic ovarian syndrome, which is a hormone imbalance due to excessive androgens, or primary ovarian insufficiency, which occurs when women's ovaries stop working normally between the age of 40. This is not the same as early menopause. Blocked uterine tubes due to pelvic inflammatory disease, endometriosis, or uterine fibroids. In addition, poor diet, being overweight, underweight, smoking, excessive alcohol consumption, stress, excessive athletic training, and age can all affect a woman's ability to conceive. Treatment for infertility in women depends on cause. Medications, including synthetic gonadotropins, may stimulate ovulation. Abdominal surgery may be necessary to clear blocked uterine tubes or remove endometriosis or fibroids. If no other treatments are successful, in vitro fertilization is an option. Oocytes and sperm from mother and father or from donors are fertilized in the laboratory and then implanted into the mother's uterus. Okay, so to wrap up the reproductive system, we're going to talk about sexually transmitted infections. Sexually transmitted infections, which is a term that's more readily used these days versus STDs or VDs, are a group of infections caused by a number of different bacteria, viruses, and parasites that are spread through sexual contact. Most common cause of reproductive disorders, oftentimes can cause infertility in adults and deformities or possible death of fetuses. So the bacterial STIs, these are pathogenic bacteria and parasites that invade tissues and cause inflammatory reactions. The first one is chlamydia. This is caused by a bacterium called Chlamydia trachomatis. It's typically asymptomatic. Symptoms, if persist, include painful urination, pain in the pelvic region and testes, and vaginal or penile discharge. Newborns, if the mother has an active infection with chlamydia, can become infected in the birth canal, and this can result in respiratory tract infections and form conjunctivitis that can lead to blindness. If left untreated in women, it can spread to the uterus and uterine tubes and cause an issue called pelvic inflammatory disease, which is inflammation of most of the reproductive structures that can lead to infertility. Gonorrhea, which is more commonly referred to as a clap, is caused by a bacterium referred to as Neisseria gonorrhea. If symptoms occur, they will include painful urination and penile discharge. Women are typically asymptomatic to gonorrhea but may experience painful urination and vaginal bleeding. If left untreated, in women, gonorrhea can lead to PID and blindness in newborns as well. This particular STI is more common in males than it is in females. And unfortunately, we've seen a little bit of an emergence of gonorrhea in the past few years in the population of men who have sex with men, gay men. This occurred because of the rollout with PrEP, which is prophylactic HIV treatment, and a lot of people have sort of ditched condoms because they suspect that they cannot get HIV, which is, PrEP is very good at what it does, but it doesn't protect against any of these other STIs. Syphilis, this is caused by T. pallidum, which will cause a small painless lesion called a canker sore. This could last up to 6 weeks after exposure. At this point, the disease is transmissible to others who come in contact with the canker sore. If syphilis has not been treated, secondary syphilis will develop after the canker has healed. This causes a pink rash all over the body. Fever and joint pain are common in this stage. Most people are usually treated with primary or secondary syphilis. If left untreated, the disease enters into a latent stage where symptoms will subside, and symptoms can come and go for years. However, eventually, it can progress to tertiary syphilis. This can produce destructive brain lesions and damages to the cardiovascular organs, brain, bones, and joints, and oftentimes tertiary syphilis can kill you. Trichopaniasis, this is caused by a protozoan referred to as T. vaginalis or T-vag. This will cause itching, burning, and redness of the genitals in women, and it may result in white to greenish vaginal discharge with a strong odor. The disease is asymptomatic in many individuals. Infection during pregnancy can lead to premature birth and low birth weights. Your viral STIs, these are caused by small non-living viruses that take over cellular organelles responsible for protein synthesis, generate new copies of themselves, and then can be released to infect new cells. HPVs, or human papillomaviruses, there are over 40 different types of HPVs, and this is the most common STI in the US. It can cause genital warts. They appear on the penis, perineum, and anus in males. They appear in the cervix, vaginal wall, perineum, and anus of females. And it's estimated that approximately 80 million sexually active Americans have been infected with HPV. Herpes, this is typically caused by human simplex virus type 2. There is also human simplex virus type 1, which most people are infected with, and that causes cold sores and fever blisters in the oral area. Many individuals infected with herpes are asymptomatic, while individuals of both genders suffer with extremely painful blisters on the external genitalia, thighs, and buttocks. Disease is easily transmissible when these blisters are present, as the virus is actively shedding, and if there's direct skin-to-skin contact. 1 in 6 sexually active Americans are suspected to be infected with genital herpes. In the Philadelphia metro area and Philadelphia city, that is 1 in 4.5. You can also spread this even if there are no fever blisters present. Spreading the infection is still a risk even during the dormant stage or time period between the blister outbreaks, and can last for weeks or years. Herpes can be passed on to newborns, causing neonatal herpes, and this can be fatal. Genital herpes can increase risk for contracting HIV and some other types of cancers. Cervical cancer is most often in women between the ages of 30 and 50, particularly those with a history of sexual transmitted infections, cervical inflammation, or multiple pregnancies. Cervical cancer can be caused by human papillomavirus, and it used to be the leading cause of cancer or death for women in the U.S. In the past few decades, both number of cases and number of deaths of cervical cancer have decreased significantly, and this is actually due to the fact that there is an HPV vaccine. The decline is due large part to pap smears, which detects precancerous cells at early stage of cancers before symptoms are noticeable, and involves the scraping of loose cells from the external os of the cervix and examining them microscopically. The cells show signs of abnormal development or dysplasia, warrant further investigation, including visual examination of the cervix or biopsy to determine if cancerous cells are present. If cancerous cells are detected, surgical removal of the tumor or even a hysterectomy, which is a removal of the uterus, may be required. In addition, radiation therapy and chemotherapy may be needed. As I said, HPV is a very common cause for this, and that's why we administer the vaccine to girls for this. However, about a decade ago, there was a huge study that came out by the American Medical Association that showed that HPVs not only cause cervical cancer, but they can cause prostate, penile, anal, throat, and penile cancers as well. When this huge study came out and showed that all these other cancers can be formed from HPV, they changed the recommendation for the vaccination, which was developed with females in mind, and administered the vaccine to both boys and girls, and that has been the recommendation for about a decade. And that is it.